Shall I start, Chitra?
Yes, sir.
So good evening, participants. Thank you for joining today on our webinar page, Shield Connect. So today we have a special speaker, and today's the topic is role of immunomodulators in respiratory tract infections. And the speaker for the day is Dr. Pradyut Waghray, and sir is from Telangana, Hyderabad. So before we go ahead, let me share a little bit idea about our Shield Connect page. So let me share the screen. So this is our page shieldconnect.in. When you log in through this page, you will able to find various sections like blog section. So you can find all the blogs written by the eminent speakers and the doctors. You will find various topics like related to COVID-19, black fungus, myoinositol. Then the second section is the webinar, where you can click on the upcoming webinar. So when you click on the upcoming webinars, you will be able to find all the webinars which will be held in the Shield Connect on various days. So like when I clicked on today's topic, you have to register, and then as you register, you will able to see our page. And in the comment section, participant, you can post your questions and feedback. So at the end of the session, we can have a Q&A with our speaker for the day. Then there is the awareness page, like an immune booster page. So we have relaunched Dodumin Mu, which will be helpful as a immune booster in this pandemic situation. So various blogs are related written on this page. Then we have a PCOS awareness page, where you can find various content related to PCOS by many doctors in the different languages like Tamil, Hindi, Malayalam, English. Then recently we have also updated COVID-19 awareness page. So you will get all the blogs and videos related to COVID. Then we have a special day pages, like if you click on the GDM page, so you will able to find all the videos related to GDM. So this is the Shield Connect page. And let me introduce our speaker for the day. So Dr. Pradyut Waghray, sir is senior consultant pulmonologist in Hyderabad. Sir has a 34 years of experience. Currently, sir is professor HOD of SVS Medical College in Mehboob Nagar. Sir is senior consultant pulmonologist in Apollo Hospital in Hyderabad and managing director of Kunal Institute of Medical Specialties Private Limited. Sir is also honorary consultant pulmonologist to the Armed Force. Sir also has a fellowship of academic of medical specialties by Indian Medical Association. Sir is also having a fellowship of the American College of Chest Physician, and sir is member of British Thoracic Society and also a gold member of European Respiratory Society. Sir recently elected as a fellow of the Royal College of Physicians, FRCP, in London, UK. Sir has many international publications and presentations to his credit. Additionally, sir also serves in COVID advisory panel for the Union Government of India. So we welcome you, sir, for today's webinar, and I will hand over the session to you. Thank you, sir. I welcome you.
Thank you. Thank you so much for your kind words, Nishant. I would just like to share my slides, and good evening to all my friends. Today, we will be talking on an important topic of immunomodulators. And I think, are you able to see my slides?
Yes, sir.
Fine. So we have seen that recurrent respiratory infections in the childhood, especially, they are predominantly viral in nature. But we have also seen that there are so many antibiotics being used and misused to treat these viral infections. Secondly, because of these viral infections, repeated viral infections, many of these children, they tend to develop virus-induced wheeze and subsequently develop asthma in later life. And so to how to prevent these things, one is the common conditions which make these children prone are of course, staying in a closed environment, crowded family, and presence of pets in the house, and then this wherever there are vaccines available against the viruses or the bacteria, they can take the vaccine, but the vaccines we know are not available for all the viruses or the bacteria. So we have to fall back on increasing our natural immunity of the child itself. So that is where the role of immunomodulators come into vogue. And this immunomodulators, which increase the immunity, has been under research for the last almost 70 years. Since 1950s, they started, and now a lot of work is being done on the role of immunomodulators and the increasing the immunity in the respiratory tract. So we know that the respiratory tract infections are those infections which involve both the upper respiratory tract and the lower respiratory tract. And the non-specific immunomodulators, which are not antigen specific, they just improve the natural immunity. As I told you, they have a long history of empirically being used for the prevention of respiratory tract infections. So what happens is these orally administered immunomodulators, what they do is they increase both the innate and the adaptive immune responses to infections in the respiratory mucosa. And not only that, they also have certain anti-inflammatory effects in those places where there is pro-inflammatory environments. So they not only increase the immunity, but also has inherent anti-inflammatory actions. If you see this slide here, what it shows is there is a definite relationship between the immunity and the ages of the patients. If you see in children at the extremes of age, the child's immune system is immature till he is around 6 or 7 or 8 years of age. Once he attains that age, then his immune system starts to mature. And then as the person increases up to 45, 50 years, the immunity is maintained. But then as again, he goes into more than 60 years and goes into the elderly population, his immunity tends to fall with age. So the immature immune system in childhood and the immunosenescence in the elderly people, that is the reason why children and elderly are more vulnerable to infections. So we have to take care of these two groups of populations. Before we actually go into the immunomodulators, let us just recapitulate what are the types of immunity present. Immunity can be divided into innate immunity and adaptive immunity. The innate immunity or the innate immune system is also known as the inborn immune system, which is there since our birth. The adaptive immunity again can be divided into natural adaptive immunity and artificial adaptive immunity. The natural adaptive immunity can be acquired passively. For example, the transfer of maternal antibodies through the breast milk when the child is breastfed, or actively, through whenever the child gets any infection. So because of that infection, they develop immunity against that particular virus or bacteria. Whereas the artificial adaptive immunity again can be obtained passively by transfer of antibodies. The good example being transfer of monoclonal antibodies, which we have used recently in the COVID pandemic. And the active artificial adaptive immunity can be achieved by the method of immunization, or what we call as a vaccination. So this is in brief about the different types of immunities and how they are acquired naturally and artificially. With this background of immunity, let us talk more about immunomodulators. The immunomodulators are both natural and synthetic compounds, which can modulate the immune response either in a positive manner when they are called immunostimulants or immunoadjuvant, or in a negative manner when they are called as immunosuppressants. So both ways they have a role to play. Now, if you divide immunomodulators, the immunostimulants can be again a non-specific immunostimulants or specific immunostimulants. The specific immunostimulants are particular against a particular virus or bacteria or infections, whereas the non-specific immunostimulants in general activate both the components of the immune system. And the role these immunostimulants play is because they enhance the defense mechanism, they are used in the treatment or prevention of infections and also certain cancers where immunotherapy is now gaining a lot of ground. Coming to the other group of immunosuppressants, again, they can be specific immunosuppressants or non-specific immunosuppressants. Their job is to suppress the immune system where there is a hyperactivity of the immune system. As for example, we have seen in the recent COVID pandemic resulting in cytokine storm. And this is used as an anti-rejection medication, mostly in organ transplantation and also in treatment of certain autoimmune diseases where they have a high amount of immunity. So we need to suppress the immunity for some time. So these are the two actions of immunomodulators. Coming to the basic principles of how these immunomodulators function, they function through their action on the B cells where they produce protective seroimmunoglobulins, and also they stimulate the T cell pathway by producing various interferons, cytokines, and interleukins, which have a protective role against infections. The various targets on which they act are numerous. To mention a few, we have the transcription factors NFK beta, free radicals and lipid peroxidation, apoptosis pathway, complement pathway, protein synthesis, and also antigen presentation. These are the various pathways on which the immunomodulators act. But predominantly, if you come to the basic principles, their role is to stimulate both the adaptive and the innate immunity, that is the B cell and the T cell immunity. So the benefits of immunomodulators, therefore, stem from their ability to stimulate both the natural and the adaptive defense mechanisms, such as the cytokines, as we have mentioned here, and which enables the body to help itself. So it raises the immune system, it raises the bar of the immunity for the body so that our own body can fight against infections on its own. Now, natural immunomodulators, they act to strengthen the immune systems which are weak and to moderate the immune systems which are overactive. Okay, so they act both ways. They can increase the immune system, and if the immune system is hyperactive, they can also reduce it and bring it to the normal level. Certain examples of immunomodulators are plant sterols and sterolins, and they are found commonly in raw fruits, green vegetables, and certain algae and spirulina. Now, coming specifically to the immunity in the lung, because we are talking predominantly of the respiratory tract infections today. Now, the lung, we know, encounters a myriad of potentially foreign bodies. When we inhale, we inhale any kind of thing inside the lungs. These large particles of these inhaled foreign bodies, they get deposited in the nasopharynx and in the tonsillar regions, and they are cleared by the initial forces of coughing and sneezing. If we get any infection here, our natural mechanism is to cough it out or sneeze it out and take those foreign bodies out. Now, if they go down, further down the respiratory tract, if the foreign body enters the lower part of the respiratory tract, they are captured on the mucociliary surface of the airways, and then they are propelled back through the mucociliary escalator. Because this mucociliary escalator consists of a hair-like microscopic structures called cilia, which have a rhythmic movement. If you remember the physiology, they have the gel sol layer. They move the mucus in rhythmic movement and tend to propel the foreign particles above and to the upper airways, and then where they are expelled. So this mucus barrier, which consists of cilia, acts as an escalator driving the foreign particles from the lower airways to the upper airways, and from there they are expelled while coughing out. Also, there are certain various number of antimicrobial compounds. That is, these compounds have action on the bacteria itself. These antimicrobial compounds exist within the mucus layer. The examples being surfactant proteins, or liposaccharide, bacterial lipopolysaccharide, LPS, which is a protein which binds to the bacterial cell walls and allowing their uptake by the immune cells like macrophages. So these are the natural immune mechanisms present, God given in our respiratory tract, which have the ability to bind to these bacteria, track them, put them into the macrophages, and then allowing them to be eaten away or destroyed by the natural immune cells, that is macrophages. That is in brief the immunity in the lung. Now, what happens when you get a viral infection? There are two steps. The immune response to responding to viral infections can be divided into two steps. The step one is the initial response, is the innate immune response. That is what we discuss as the natural inborn immunity, which is a general response to any infection. Whenever we get any infection, our innate immune system comes into action. What happens? This innate immune system, it secretes certain cells called interferons and cytokines. Now, these interferons and cytokines, what they do, they interfere with the virus, prevent its replication, and destroy the virus. When they are doing this action of destroying the virus, these interferons and cytokines cause fever, muscle ache, etc., which we all experience when we get any sort of a viral infection. The reason for the fever, the myalgia, the body pains, which are early signs of any viral infection, is because during this infection, our innate immune system is responding. It is liberating interferons and chemical cytokines to fight these viruses, and that's why this is the healthy response what we get. And most of the time, the infections can be stopped at this stage itself if your innate immunity is strong. But sometimes what happens, once our innate immune response is weak, for example, as we have told in children or in the elderly population or population with some underlying immune problems or health problems, then when this weak innate immune response is there, this may result in a delayed stimulation when the adaptive response comes into force. That is the stage when the innate immunity is unable to hand this infection. The step 2 is triggered. The step 2 is the adaptive immune response, which is a specific response to the infection. Here, the antibodies are formed specifically to that infection. But this generally starts 6 to 8 days after the onset of the infection. When the innate immunity fails, the adaptive immunity comes into action after a week. And this adaptive immunity involves two types of cells, the T cells and the B cells, which produce specific antibodies against those viruses and bacteria, and then they try to contain the infection. Now, what is the role of, with this background of immunity, now let us see what is the role of immunomodulation to prevent recurrent respiratory tract infections. Okay, now recurrent respiratory tract infections are very commonly seen in the pediatric population. I'm sure all of the pediatricians must have encountered many respiratory infections in their children population. Now, it is called recurrent respiratory infection when there are 8 or more episodes in a year in infants, or 6 or more episodes in children who are more than 3 years old. And then technically we call it recurrent, but this is only in numbers, say. So basically it depends on the more infections the child has. We have seen that childhood itself, with its temporary immature immune system, this itself may be the primary cause of the occurrence of recurrent respiratory tract infections in this pediatric population. We also know that viruses are responsible for most of these respiratory tract infections, comprising more than 80%. The common viruses affecting the pediatric respiratory infections include human rhinovirus, respiratory syncytial virus, adenoviruses, and the influenza virus. But sometimes the bacteria species also may be the etiological agents. When most of the time they are occurring, they follow the viral infections like a super infections, or sometimes they can affect alone as well. And these infections, these viral infections cause and contribute sometimes to serious respiratory conditions which may necessitate the child to be hospitalized, as we had seen in the earlier H1N1 influenza, and now we are seeing in the COVID epidemic. So then what are the risk factors for causing this recurrent respiratory infections? These are all the risk factors to mention a few. Early socialization in the pediatric age group, whenever there's a large family size with overcrowding, improper ventilation, and the child has a positive family history of any atopic diseases. Especially this is seen in school age siblings because they are mixing with other children as well. If the child born is a premature history of premature birth or low body weight infants, when the child is not breastfed by the mother, the transfer of maternal antibodies doesn't take place and is more prone to develop recurrent respiratory infections. Certain indoor and outdoor pollutions, presence of pets at home, dampness at home, all these make them more vulnerable. The important thing is parental smoking, and smoking in pregnancy can make the child more vulnerable to recurrent respiratory infections. Certain anatomic or functional alterations of the upper or lower airways, presence of allergy or atopy history, gastroesophageal reflux, predisposed to recurrent respiratory infections. For some reason, the male genders are more vulnerable, they say, when compared to females. And then again, of course, if there is a missed vaccination, they are more prone. These are the common risk factors which make the child suffer from recurrent respiratory infections. They are predominantly the targets where you can use these immunomodulators. So what is the rationale for the use of immunomodulators in respiratory tract infections and also in preventing wheezing and asthma control? See, the mechanistic rationale for the use of orally administered immunomodulators for the prevention of respiratory infections centers on one gut-lung immune axis. I will explain to you what is meant by gut-lung immune axis. Now, a lot of research is telling that all the immune system is basically developed from the gut, and then from there the lung gets protected. So this gut-lung immune axis is the most important component of the role of immunoprotection. Now, what happens here is the antigen sampling. So this is the gut-associated lymphoid tissue present in the Peyer's patches. These are the M cell and these are the dendritic cells. So the antigen supply by M cells and by the dendritic cells located in the Peyer's patches of the gut-associated lymphoid tissue. Those antigens or infections which are presented to the M cells and the dendritic cells located in the Peyer's patches of the gut, they lead to maturation of these dendritic cells. These dendritic cells are matured and then they present the antigens to the various other immune systems. So this matured dendritic cells changes into an antigen presenting cell phenotype. This dendritic cell presents the antigen to the immune components of the immunity. What happens? The subsequent dendritic cell initiated immune cascade then involves homing of cells from both the innate and the adaptive immunity, that is the T cells and the B cells. And then once this homing of the T cells and B cells occur, which are both branches of the immune system, this is then shifted to the mucosal associated lymphoid tissue of the lungs, that is here, and that is where the immunity and antibody production forms. So the dendritic cell initiated immune cascade from the gut Peyer's patches involves homing of cells from both the innate and adaptive branches of the immune system to the mucosal associated lymphoid tissue of the lungs, and then results in subsequent antibody production. That is very important. That's why they say a healthy gut is a route to a healthy lungs. That's where the role of lot of probiotics are coming into vogue now. This is a diagrammatic representation of the gut-lung immune axis. This is illustrating the various points which I have discussed just now. The antigen, these are the pathogen associated molecular patterns which are presenting the antigen to the M cell and then to the dendritic cell. This dendritic cell matures, carries the antigen and presents to the various immune components, including the macrophages, neutrophils, monocytes, and also the B lymphocytes. And when this occurs, there is a homing of both the T cells and the B cells, and then this results in production of antibodies, both IgG and IgA, and also CD8 and CD4 lymphocytes in the lung-associated immune system. So the work starts in the gut and then progresses to the lung. So with this background, this is the most important diagram of the talk today. And once you understand this concept of the gut-lung immune axis, how the immunity process starts in the gut and then it migrates to the lung to result in production of antibodies. Then from here, keeping this in mind, we now move on to the various immunomodulators available and how they act at different levels. The first one to come and which was discovered was OM85. OM85 is an alkaline lysis of 21 strains. It contains alkaline components of 21 strains of the 8 species of common respiratory pathogens: Haemophilus influenzae, Streptococcus pneumoniae, Klebsiella pneumoniae, Klebsiella ozoni, Staphylococcus aureus, Streptococcus pyogenes, viridans, and Moraxella. These are the common bacteria which affects children and even the elderly population. So this OM85 is an extract of these 8 common bacteria. So what they do is they cause maturation of the dendritic cells, and they stimulate both innate and adaptive cytokine release. When you come to innate immunity, these OM85, which is immunomodulator, it helps in the release of antimicrobial peptides, number one. Number two, it results in a rapid neutrophil recruitment whenever there is any viral infection and helps in containing the infection. It promotes certain cytokines which stimulates the NK cells, that's the natural killer cells, monocytes, phagocytosis, and neutrophils. It also causes the macrophage activation and releases the interferon beta, which is a strong antiviral cytokine. In the adaptive immunity, these dendritic cells causes T cell activation, both the CD8 and the CD4 cells, and also helps in formation of serum immunoglobulin G and immunoglobulin A, and also forms the production of interferon gamma. So these are all represented. The blue, the capsule here is OM85, and these are all representing the various actions on both the innate and the adaptive immunity what I have discussed. The second immunomodulator available in the market now is pedotimod, which is a synthetic thymic dipeptide. The OM85 is a natural, this is a synthetic thymic dipeptide. This again causes maturation of the dendritic cells, making it to present the antigen or an antigen presenting cell. This acts by certain mechanisms like toll-like receptor 2. If you see this diagram, by its action here, toll-like receptor 2, TLR2, it causes stimulation of the dendritic cells, and then this presents the antigen and cause a significant innate and adaptive cytokine release. This also results in release of antimicrobial peptides, improves the mucociliary transport, and also stimulates the NK cells, neutrophils, etc. And also it helps in stimulation of the CD4, CD8 cells and the formation of antibodies. The third component, what we see here, is the ribofulin. Ribofulin is also another immunomodulator, which is actually a mixture of bacterial proteoglycans and ribosomes of common respiratory tract pathogens which affect the respiratory system. This also causes maturation of the dendritic cells and stimulation of the innate and adaptive cytokine release, resulting in production of both powerful T cells, B cells, interferon, gamma, and also salivary IgA and IgG. So what it means is all these immunomodulators are stimulating the gut-associated lymphoid tissue, stimulating the dendritic cells which presents this antigen, and then it results in production of antibodies by the respiratory system. So that is the most important part which we must understand today. So summarizing these three immunomodulators as in the respiratory infections, OM85 is the product of alkaline lysis of 21 strains of common bacterial respiratory tract pathogens. This induces dendritic cell maturation, causes release of chemokines that act on monocytes and natural killer cells, and then demonstrates efficacy in a number of pediatric respiratory infections. Similarly, pedotimod is a synthetic thymic peptide, causes maturation of mucosal dendritic cells, promotes proliferation of T cells, monocytes, and cytokines, and reduction in the clinical symptoms of fever, cough, and also the clinical signs like reduction in pulmonary rates. It also reduces the duration of infection. Ribofulin, we said, is a mixture of proteoglycans and ribosomes. It induces also dendritic cells and stimulates both the immune components, T and B cell, and it also reduces incidence, prevalence, and or duration of infection. So this is the role of immunomodulators in recurrent respiratory infections in pediatric and in the elderly population, especially in the pediatric population. Now we change gears. We move on from the prevention of recurrent respiratory infections to the adult population. That is role of immune system in COPD. COPD, we all know, is one of the almost the third leading cause of death, slowly going to be jumping to the second leading cause of death all over the world. And in India, they say about 35 million people, they are suffering from COPD as of now. So what is the correlation between immunity and COPD? These COPD patients are found to have decreased or compromised immune status, where both the innate and the adaptive immunity have been found to be compromised. The immune status of a COPD is exactly the same to that seen in elderly man due to aging, what we call as immunosenescence. But in COPD, this senescence of the immunity, or this occurs much earlier in age, and it occurs in an exaggerated stage. Okay, so this premature and exaggerated impaired immune system in COPD is due to the exposure to smoking, various noxious agents, and recurrent respiratory infections. Now we will see how this COPD is, how the immunity gets reduced in COPD. If you see the basic lung innate immune system, it comprises 5 components: the airway epithelial barrier, the alveolar macrophages, the dendritic cells, the neutrophils, and the natural killer cells. Now let us see how COPD affects each of these components of the lung innate immune system. Coming to the epithelial barrier first, in COPD what happens? There is a decreased epithelial integrity, that is the cilia which are normally present well. Here there's a loss of cilia or there's a blunting of cilia. So this results in decreased ciliary beating. Number 2, there is decreased production of a component called secretory leukoprotease inhibitor. This secretory leukoprotease inhibitor is produced by our lungs, by the epithelial cells, to fight the infections and also to reduce the neutrophil elastase activity. So once this antimicrobial peptide SLPI is decreased in COPD, it makes them more prone to develop respiratory infections. Then also there is a goblet cell hyperplasia resulting in more mucus production. That's why the thick sputum blocks COPD airways, and there is a decrease in the surfactant production. Then we come to the next component, that is alveolar macrophages. And the alveolar macrophages in COPD, though they are increased in number, but the macrophages which are produced in COPD, they are predominantly of the M1 and M2 type. Now these M1, M2 macrophages are developed due to the injurious effects of cigarette smoke, oxidative stress, etc. These macrophages, which are increase in number, but they do not have that much of a phagocytotic activity. In fact, these M1 and M2, they cause increased inflammation, increased oxidative stress, and increased production of metalloproteinase MMP 9 and 12. And all these macrophages accumulates in the areas of the emphysematous destruction of the lung in COPD, and there is a strong correlation have been found between the numbers of this defective macrophages and the severity of the COPD obstruction. So what happens once these macrophages lose their capacity or reduce their capacity to phagocytose the bacteria, which are commonly found to be present in the lungs of the COPD patients? They are unable to phagocytose this bacteria, resulting in increasing bacterial colonization and recurrent bacterial or viral exacerbations. So both the production of these inflammatory macrophages and the recurrent infections result in further lung remodeling and damage, and therefore worsen the COPD condition. The third component of the innate immune system affected in the lung by COPD is the dendritic cells. Dendritic cells are the most important component. They are a specialized population of mononuclear cells, and their job, as we have seen earlier, is to recognize and uptake of the pathogenic material coming into the lung. Now in COPD, there is a the immature dendritic cells are found to be very large in number in the small areas of COPD. And these immature dendritic cells, they produce a marker called langerine. So this langarine is increased in COPD patients, suggesting the presence of more number of immature dendritic cells in their lung rather than the mature dendritic cells. The fourth component of our innate immunity is the neutrophils. The job of neutrophils is to phagocytose the bacteria and to release certain antimicrobial or antibacterial factors which actually nullify these highly reactive oxidants released by the bacteria, and therefore they inactivate the pathogens. Now in COPD patients, this neutrophil mediated response is reduced, and in fact this response is directed against the patient's lung tissue itself. Therefore, increased number of neutrophils are observed in COPD wherever there is an increased amount of lung destruction. So more the lung destruction, the more the neutrophils are found there. So here the neutrophils are revolting, they are acting against preventing rather than preventing their damage in the lung itself in COPD patients. The fifth component and the last component of the innate immune system in COPD are the natural killer cells. The job of these natural killer cells is to recognize the virus infected cells or the stressed out cells, and then when these infected cells are recognized, they secrete certain substances called tumor necrosis factor alpha, interferon gamma, and interleukin 12. Now these three components, they result in the cytotoxic activity. They kill the cells of causing this bacterial infection, and everything goes all right. But in COPD patients, this activity of the natural killer cells have been found to be reduced. The marker for this is perforin. So there is a decreased perforin expression, suggesting a decreased natural killer cell activity in the COPD patients. So this is just to summarize what we have told, the innate immunity changes which are present, how they are affecting in a COPD patients and how they are affected. Then, so what happens to this disordered innate immunity in COPD patients? We know that these immunity disorders are occurring in COPD patients. So what do? This disordered innate immunity in a COPD patient, due to the exposure to environmental pollutants, they decrease the innate immunity, resulting in recurrent respiratory infections, causing inflammation. And again, becomes a vicious circle. The more immunity loss is there, more infections, more inflammation. So this circle continues, and this results in progressive lung destruction and a progression of the COPD as well. So this is what exactly happens when there is innate immunity associated with infection. So if you see both the COPD itself and the infection in COPD, both are affecting the innate immune system of the lung, thereby causing a progressive lung damage in the COPD patients. This is a diagrammatic representation of what happens. Both innate immunity and adaptive immunity are reduced, decreased neutrophil and chemotaxis, phagocytosis, decreased NK cell activity, decreased dendritic cell maturation. This results in the reduction of the T helper cells. So there is a reduction in the TH-TS ratio, that is T helper cells are less than T suppressor cells. So they are unable to fight the antigens. There is decreased production of immunoglobulin A, which is responsible for producing more of antibodies from the plasma cells. So all these reductions in both the innate and the adaptive immunity make these COPD patients more susceptible to develop recurrent respiratory infections. The recovery time from each infection is delayed and resulting in frequent hospitalization. So then how do you manage COPD in the current scenario? We all know that these patients need inhalers as per the gold guidelines, but now it is changing that COPD represents, we know it's a state of impaired immunity. So unless you improve their immunity by giving only the inhaled medication, it is not going to help these people. So they have impaired immunity, they have decreased antimicrobial activities, and therefore they are more susceptible to infections and increasing inflammation. And this decreased immunity, recurrent respiratory infections and COPD are the commonest cause of COPD exacerbations, hospitalizations, morbidity, economic cost, etc. So prospective therapies for COPD, in addition to the inhaled therapy as guided by the GOLD guidelines, it should include therapy aimed at normalization of the immune responses. So that is the role of immunity in COPD. Our third and component is, now we move on to the COVID and immunity. This we will discuss what happens to immunity in COVID as such. COVID, we all know, again, is a virus infection. So this is exactly the same thing. what occurs in any other viral infection or bacterial infection, which we have discussed. Both the innate immunity and the adaptive immunity are reduced here also, but then there are certain specific things with regard to COVID. Coming to COVID and immunity, see, COVID usually affects the respiratory, the airway epithelial cells, respiratory alveolar epithelial cells, and also the vascular endothelial cells. So whenever there is a dysfunctional immune response in COVID-19 patients, the vascular infiltration occurs because of excessive infiltration of the T cells and the macrophages, which actually destroy these vascular endothelial cells. They release various cytokines, what we call as the cytokine storm, which damage the endothelial cell, make it more permeable, resulting in pulmonary edema, infections like pneumonia, and then widespread inflammation and multi-organ affection. That is what happens in the dysfunctional immune response in these COVID-19 patients. Versus a healthy immune response, what happens whenever the virus infects the cells? This virus in a healthy immune response is inactivated by the neutralizing antibodies produced by the immune system. And these viruses which are neutralized or inactivated by these antibodies are immediately cleared up and taken up by the macrophages and rapidly cleared off, therefore resulting in very minimal inflammation and lung damage, unlike in the dysfunctional immune response. And for this to happen, for this effective immune response to happen against viral infection, this has been found to depend on activation of the cytotoxic T cells. That is, more the activation of the cytotoxic T cells, the more healthier is the immune response. Now, in COVID patients, it has been found that there is a significant reduction in the circulating lymphocyte counts in COVID-19 patients. We all know that the lower the lymphocyte count in COVID-19 patient, the severe is the infection. And this is found, this low lymphocyte count is found in a whopping 82% of the patients of COVID-19 cases. So that is the reason why these COVID-19 patients, because of this low amount of cytotoxic T cells, are not able to fight infections and they are developing into complications. At the granular level, these are the background of the innate immunity and the adaptive immunity. What happens is, in the innate immunity, in COVID-19 infection, the total T cell counts, CD4 component and the CD8 component, all these three are significantly reduced. Therefore, they are unable to produce more of cytotoxic T cells. Therefore, the viral survival continues, prolonging the COVID virus infection, resulting in more severe symptoms and increasing mortality. Okay, so the virus replication in the immune cells is now prevented from being killed. Then, in coming to the adaptive arm of immunity, in COVID patients, there is induction of neutrophils, the monocytes, the macrophages, and the dendritic cells. And this results in production of various pro-inflammatory cytokines like tumor necrosis factor alpha, IL-6 and IL-10, and which result in the so-called cytokine storm because of the hyperproduction of these pro-inflammatory cytokines. So this leads to the vascular endothelial damage, the lung edema, tissue damage. And whenever there is a high levels of pro-inflammatory cytokines, again, various types of immune cells are mobilized, like neutrophils, macrophages, and T cells. They are mobilized from the blood circulation into the infected tissue, and they cause damage to the infected tissue. Okay, so this damage by these pro-inflammatory cells and cytokines lead to diffuse alveolar damage, capillary damage, vascular barrier endothelial cell damage, and that is resulting in permeability of the fluid, what we call as ARDS, multi-organ damage, and ultimately death. So that is what is happening at the cellular level in these COVID-19 patients. So then what we can do, what's the role of immunomodulators in COVID-19? This is broadly a chart to show that here what they are showing is the peach boxes are showing the mechanisms of cell injury and how they damage, and the green boxes are showing the potential therapeutic options. So we know that the virus infection occurs by the binding to ACE2 receptors, then the virus enters, replicates, and maturation occurs. So anything which, to reduce this viral load or replication, drugs have been tried like remdesivir, baricitinib, etc. Then we know that there is activation of T cells, monocytes, and macrophages, the release of various inflammatory mediators. So various targets like tocilizumab for IL-6, steroids, Dexamethasone, we know it has been used in anti-inflammatory action. IL-1, drugs anti-IL-1 like anakinra, Janus kinase inhibitors like baricitinib, TNF-alpha like adalimumab is now going to come soon, and colchicine, which was very commonly used in both the waves of COVID attacks by reducing the inflammasome component of the inflammation. So that's the role of colchicine. And then again, because of activation and release of many inflammatory mediators, role of antimicrobials like azithromycin was used. And of course, the alveolar macrophages, we know that they clear the neutralized viruses. So again, the improvement of innate and adaptive immunity is important in these patients. Now we'll talk about a little bit about pidotimod, because there is some work done with pidotimod. This is as you remember the earlier slides, is the second immunomodulator we discussed. This is a synthetic dipeptide molecule with immunomodulatory properties. It is an immunostimulant, immunoactivator, and immunomodulator, and it's an oral synthetic biological response modifier. What is its role in immunity with specific reference to COVID? It upregulates both the innate and the adaptive immunity in these COVID patients. It induces dendritic cell maturation, which we have seen just now. It downregulates the monocyte chemoattractant protein 1, MCP1. What does this MCP1 do? The MCP1, its job is to recruit the pro-inflammatory cells like monocytes, macrophages, neutrophils. All it recruits from the blood to the sites of inflammation and causes more and more of tissue injury. So that is the job of the MCP1. So this drug is downregulates, means it impairs or it reduces the action of MCP1, therefore preventing the release of these pro-inflammatory cytokines and therefore helping in controlling the cytokine storm activation. It's a very, very important role that this drug plays. It also upregulates the toll-like receptor 2, thereby it's preventing lung damage. Then it also upregulates the adaptive immunity, because we know it helps in T cell proliferation and thus reduces the duration of symptoms. This diagram beautifully tells us how does this drug acts. See, it improves if you remember the 5 components what I have told you, it improves the ciliary function. Number 2, it increases the maturity of the dendritic cells, and by maturing these dendritic cells, because in COPD or any infections, we know that the dendritic cells are immature, so it makes these cells mature and they increase the natural killer cell activity. They increase the phagocytic activity of the macrophages and the neutrophils, and all this action they do by upregulating of the toll-like receptor 2. On the antibody side, it also increases the interferon gamma. By increasing interferon gamma, it causes more of a Th1 balance when compared to Th2, and thereby it improves the production of T helper cells when compared to T suppressor cells. So there are more of T helper cells produced, which we have seen that in COVID patients, the T lymphocytes are reduced. So by increasing the T helper lymphocytes, it increases the capacity to fight infection. It improves the Th1, Th2 balance. By reducing interleukin 4, which is a pro-inflammatory cytokine, it reduces the formation of immunoglobulin E, thereby also having a role in preventing of wheezing and allergic asthma. And also it helps in promotion of the protective immunoglobulins G and IgA, immunoglobulin G and immunoglobulin A. So these are all the wonderful actions of this drug. It improves both the innate immunity as well as the adaptive immunity. So this has a very good role in preventing this immune imbalance in COVID patients as well. In respiratory infections, any infection, what happens? It is because there is a predominant imbalance of the Th1, Th2 function. So this drug, it downregulates the production of interleukin 4, as we have seen here, and therefore it favors the production of Th1, interferon gamma, and IL-12. Therefore, its anti-infection ability increases. This is a study done in COVID patients. What happens in COVID patients? We have seen that this is the healthy non-ICU and ICU COVID patients. It was found that the counts of the T cells, total T cells, CD4 and CD8, all were found to be significantly lower in the ICU patients when compared to the non-ICU patients. Again, suggesting that the lower the lymphocyte count, the more are the complications of these COVID patients. So their reason for getting into the ICUs. It was also studied, this was in China, I think, and they said the T cell count are significantly reduced in COVID patients, and whatever T cells are surviving, they are also functionally incompetent. So here they studied both they measured the T cell populations in moderate COVID, severe COVID, critical COVID, and those who have died. We know that COVID can be divided into mild, moderate, severe, and critical. So the more severe and critical patients and those patients who expired, they were found to have a significantly low T cell count, CD4 and CD8. So therefore, boosting the numbers of these T cells and also boosting the function of these T cells is important in the current pandemic. So what can our immunomodulators do here? If you see some research is done with pidotimod. Now, if you see the first problem, in the host immune response to virus is more, reduction in production of more of pro-inflammatory cytokines causing lung injury and resulting in permeability increase and pneumonia, pulmonary edema, and then ARDS. Pidotimod, we know by upregulating the TLR2 receptors, decreasing the susceptibility to neutrophil mediated pulmonary parenchymal injury, prevents the lung injury, and therefore it rebalances the immune status and it prevents the evolution of infection. So here, because there is a hyperimmune response, this drug rebalances by action on toll-like receptor 2, and therefore it prevents the spread of the infection. Number 2, we have seen that in COVID, there is increased levels of plasma pro-inflammatory mediators, which are the cause of the so-called cytokine storm. We have seen that by decreasing or by inhibiting the action of monocyte chemoattractant 1 protein, MCP1 protein, pidotimod regulates the inflammatory response and therefore helps in preventing the cytokine cascade activation. Third, we have seen that there is a total cell count reduction significantly in these COVID patients, favoring increase of symptoms and complications and disease progression. Again, the pidotimod has been found to increase maturation of mucosal dendritic cells, production of more powerful T cells, and therefore it is found to reduce the duration of symptoms in patients of COVID. This was a small study done in Italy, where they studied about 20 SARS-CoV patients, were done in outpatient, were mild to moderate COVID patients. They were put on pidotimod group A, that is this group, which received 800 milligrams twice a day for 10 days. And this is the control group, which did not receive pidotimod and it received only the symptomatic treatment. And it was found, if you see here, the clinical defervescence, that is reduction in the duration of symptoms of fever, etc., were much earlier on day 4 in the pidotimod group, whereas in the control group, it took almost double the time, 8 days or 9 days to resolve. Not only that, it was also found that there is increased secretion of interferon gamma and decreased production of interleukin 6. So it also helps to prevent the cytokine cascade activation. There is a paper, which my paper also is going to get published soon. We did a study on 175 patients of COVID during the first and the second wave with pidotimod and with curcumin, and both have been found to show excellent results in preventing these patients from going into complications. So I think hopefully by the end of this year, those 2 papers also will be ready for publication. It's a very safe drug. Apart from mild nausea or some headache, there is no other significant side effects with pidotimod. And so the key points here to know is the diversity of the individual innate and adaptive immune responses may contribute to the clinical manifestation of SARS-CoV-2. And then we know that immunological memory to SARS-CoV-2 has been demonstrated in patients who are in their convalescing from the severe and mild COVID-19 patients. So this will affect the vaccination protocols as well. Then we talk about slightly about vitamin D, because everybody is using vitamin D. So what is the role of immunomodulatory role of vitamin D? There is a strong correlation between vitamin D reduction and chronic inflammatory diseases. We know that 80% of vitamin D comes from the endogenous production from 7-hydrocholesterol present in the skin when it gets exposed to the ultraviolet rays from the sun. Then vitamin D3 is the form that is stored in tissues such as the liver and adipocytes. The prohormone requires 2 hydroxylations to occur. first in the liver and second in the kidney to become the biologically active form of vitamin D. Okay, and this vitamin D in the activated form is a strong immunomodulator with beneficial effects on again on the T cell mediated autoimmune diseases. That is why we are recommending vitamin D in this COVID patients, because they also enhance the T cell mediated immune response. Again, this vitamin D3 supplementation has been found to improve the Th1 Th2 cytokine ratio, and decreased levels of vitamin D contribute to the inflammatory autoimmune process and the progression of all the complications. These are the simple strategies which boost our respiratory immunity. This is a common sense: get enough sleep, eat more of plant foods, healthy fats, a probiotic, as I told you, because the concept of probiotic came from the gut-lung immune axis, what we discussed in detail. Stay hydrated, and of course, manage your stress levels. So in summary, what all we have talked, I think because of immunological immaturity and the increasing reliance of high-risk mixed social environments, recurrent respiratory tract infections cause a major burden of care. Now, despite their overwhelmingly viral cause, still RTIs are a significant source of antibiotic misuse and are associated, therefore, with both direct cause and also an increased risk of wheezing and virus-associated wheeze and asthma. Therefore, prevention is the key in order to reduce this burden of care and the associated increased risk of recurrent respiratory tract infections. COPD, we know, is characterized by an abnormal immune response in the lower airways, and this is associated with infiltration of the lung by both the innate and adaptive inflammatory immune cells, causing more and more of infection, inflammation, and respiratory damage. This abnormal immune response makes the COPD patients more prone to infections, which lead to COPD exacerbations and hospitalizations. Therefore, immunostimulants can be used and should be used in the management of COPD and AE-COPD along with standard of care. So thank you so much. I think I have conveyed the message. Any questions, I will be glad to answer.
Okay, sir. Thank you so much for giving the so much of information regarding immunomodulators in COVID and respiratory infections. So let me check if we have any questions in the comment section. So, sir, one question is that is curcumin helpful in repairing the damage which is done in the pulmonary in the COVID patient, post-COVID patient?
Yes, as I have told you, about my paper is going to be published in the next couple of months. We have done the studies on COVID patients, and this curcumin also is a very strong immunomodulator. It prevents, rather it stimulates against the T cell immunity, and it prevents the production of various pro-inflammatory cytokines. In fact, it acts at various levels. It prevents the entry of the virus into the cell, prevents the viral replication, and prevents also the damage caused by the virus by the production of pro-inflammatory cytokines. See, most of the time what happens, we are targeting the ACE2 receptor. We all think that the COVID virus attaches to ACE2 receptors. It's not the only case. There are again 3 or 4 more receptors to which the virus attaches. Predominantly, the drugs are being produced like to block this ACE2 receptor blocking by the virus. But what about the other receptors? So curcumin, it has been found to prevent the virus infection from all these receptors. And whatever virus has managed to enter the cell, this drug also prevents the viral replication. So I think it's a wonderful drug. What the literature shows is the nano formulations of curcumin are better options when compared to oral. But then oral itself is available right now. And the only problem with the bioavailability of oral medications may not be as much as we expect. So we have to give a slightly higher dose than required. But once the nano formulation comes, which I heard that is already in the pipeline, they will be a wonder drug, not only for COVID, but for any other respiratory infections, COPD, asthma, etc.
Then, sir, there is a general question that should routine spirometry and lung function control be performed in the asthmatic patient during this COVID-19 pandemic situation?
No, the guidelines say, if you see the GINA guidelines, they say we should not do the lung functions unless it is going to change your diagnosis. because you are likely to transmit infections by the mouthpieces. So by and large, basically go by a clinical diagnosis, and you can give a peak flow meter to the patient to use for his personal use. And by blowing on the peak flow meter, you can see whether there's a reduction in the peak expiratory flow rate rather than doing a full-fledged lung function test. So the answer is try to avoid doing lung function test just to make a diagnosis, because it's a clinical diagnosis predominantly. But if you have to do it, then, for example, if you are doubting asthma or COPD and if you want to do a test, then take full precautions, use disposable, sterilize, and then do the test. But as per the guidelines, try to avoid doing a lung function as much as possible during the pandemic.
Then the third question is, are pregnant women with the respiratory infection or any kind of respiratory disease, are they on the high risk to have a COVID-19 infection?
Pregnancy by itself does not increase the risk of getting COVID-19 infection. Okay, but if a pregnant woman gets COVID-19, the incidence of complications are likely to be more in pregnant women. I hope you understood. Okay, so if unfortunately if a pregnant lady gets COVID and if she has underlying respiratory problems, then the complications from COVID are more in these patients. So that's why it's all the more important to prevent. That's why the vaccinations also have come into the guidelines for the pregnant ladies now. It is important to vaccinate the pregnant lady, and it is also important to see that the existing respiratory conditions like asthma, anything, they have to be under control all through the pregnancy.
Thank you so much for giving all this information and providing all the answer to the questions. And I also thanks all the participants for having joined to this session. And can we have one video on our product, sir? Can I play it?
Yeah, please go ahead.
Thank you, sir.
Dr. Shield Healthcare, transforming health with innovation and technology, is the winner of the prestigious Indian Health and Wellness Award. Likes to thank you for helping us achieve through your valuable partnership. Health issues like recurrent respiratory infections can cause complex physiological and biochemical changes leading to ambulatory condition. Therefore, we need a specific immune booster to strengthen the respiratory immunity. So, introducing Rudimin Mu tablets and Rudimin Mu syrup to strengthen the respiratory immunity. Rudimin Mu tablets and syrup are a specific combination of 4 bioactive ingredients along with immunovitamins and minerals. The bioactive ingredients are tinocoridin, curcuminoids, aciminin, Osimum sanctum. Rudimin Mu is also enriched with immunovitamins like vitamin A, vitamin C, vitamin D3 and minerals like zinc and selenium. As per ESPN guidelines May 20, daily allowance of vitamins, minerals and trace elements maximizes nutritional defense for patients susceptible to frequent respiratory infections. Therefore, please prescribe Rudimin Mu tablets and syrup in recurrent respiratory infections. Only Rudimin Mu strengthens the respiratory immunity. Dose of Rudimin Mu tablet is 1 tablet BID. Dose of Rudimin Mu syrup is 5 ml BID. Doctor, Rudimin Mu shields immunity. Thank you.
Thank you so much, sir. And sir, one more question is there, whether tinocoridin can be used as an immunomodulator?
Yes, I think we have just shown in the video as well. Yeah. And I think it's a good immunomodulator, and the actions are also well seen just now, again by acting on the increasing the T lymphocyte count. I think yes, it can be used and it should be used. See, rather than using general vitamins, multivitamins, better to go and add these immunomodulators because they are going to play some good role in preventing these infections.
And one more question, that phytochemicals are more good as a respiratory immunomodulator when compared to corticosteroids?
See,
now?
as I told you, corticosteroids are immunosuppressants. They reduce the inflammatory response. So with regard to the present COVID crisis, at what stage you should use the immunomodulators, at what stage you should use the steroids. Now, if you are using the the natural immunomodulators, they have to be used in the early on, so that they're preventing the viral entry, preventing viral multiplication, preventing release of inflammatory mediators. Okay, and once the inflammatory mediators have been released and the patient enters the second week, then the multiplication has stopped already. So you have missed the bus. So start it early. Then the role of steroids will come, because we have to reduce the anti-inflammatory, pro-inflammatory cytokines. So it is important to know when to start which drug. Don't start steroids early. Steroids are meant to be started at a particular time to reduce the inflammation, probably after the second week. Whereas the immunomodulators can be used both at the beginning, as well as we have seen that they reduce the cytokine storm, so they can be continued all through the COVID treatment. In fact, the trial what we have done with these pidotimod and curcumin, we continued for about 10 to 14 days of drugs, these two drugs. And most of our patients, they were prevented from getting admitted to hospital, and most of them prevented from going into complications and in the ICU. So it's a very, very positive results we got, and hope we have sent it to ICMR also. So hopefully it will come soon.
Thank you, sir. Thank you so much for giving all the informative knowledge with our participant, as well as even I got to know many things about this topic today. And I also thank our Shield colleagues and Mr. Uma Shankar, who made this webinar possible today with you, sir. And we are glad to have you again on our platform, and we will like to have more sessions with you further in the future on Shield Connect. Thank you so much, sir.
Thank you. Thank you.
Thank you, sir. Thank you very much,
Thank
sir.
you.